Hello and welcome to RCSI University of Medicine and Health Sciences. I am Professor Alice Stanton, and today we are going to discuss supporting your cardiovascular and heart health. This panel discussion forms part of RCSI's MyHealth Series. The series explores a wide range of areas in health and well-being and brings together leading healthcare experts in these fields, with the goal of empowering people with the knowledge to make informed decisions and choices about their own health and well-being. Today, I am joined by Professor Robert Byrne, Director of Cardiology at the Mater Private Hospital, Dublin, and Chair of Cardiovascular Research, RCSI University of Medicine and Health Sciences. Also by Professor Anne Hickey, Professor of Psychology and Deputy Dean for Positive Education, RCSI University of Medicine and Health Sciences, and also Principal Investigator of the Post-Stroke Cognition Research Group. And lastly, by Professor David Williams, Professor of Stroke Medicine, Beaumont Hospital and RCSI University of Medicine and Health Sciences. Welcome to the RCSI MyHealth Series. We have received a lot of questions in advance of today's discussion from the MyHealth audience, and we've tried to cover as many of those questions and themes as possible in our discussion today. So Robert, I'm going to turn to you first. Can I start by asking you to explain to our viewers what is meant by cardiovascular disease?
Yeah, so thanks very much for the invitation to be here. I think that's a good place to start. Cardiovascular disease is really a broad term. It refers to disease of the heart or of the connected circulatory system. When we talk about heart disease, we tend to think about it in a couple of different ways. We think of disease of the coronary arteries, which are the arteries that supply the heart muscle with blood. We think of disease of the heart muscle itself. We think of heart rhythm abnormalities and a variety of other disorders. Then vascular disease tends to be a term we use for diseases that affect the same circulatory system outside of the heart. And they might be narrowings in the arteries to the legs, narrowings in the arteries to the head, which can cause stroke, or narrowings indeed in other parts of the body, like the kidney arteries. So it's a relatively broad term and encompasses a wide spectrum of diseases.
Okay, and focusing in on the heart and heart diseases, so probably heart attacks and heart failure and heart irregularities will be the most common types of heart disease. So what would people experience? What signs and symptoms would they experience if they were having one of those events?
So if we start maybe with diseases of the heart arteries, which are common, coronary artery disease, and there's a couple of symptoms to watch out for there. And narrowings in the heart arteries can occur slowly over time and give you gradual symptoms, or they can occur abruptly and give you a sudden onset of symptoms. The classical symptom, I suppose, is a symptom that's called angina, and many people are familiar with the term. It refers to a type of constricting discomfort in the chest. Usually it's a symptom that's brought on by exercise, and classically it's relieved by rest. And that's the picture in somebody who has a gradual onset of heart disease related to narrowings in the heart arteries. Sometimes people don't perceive a discomfort or a pain in the chest, rather breathlessness when they push themselves, and that might be another sign of heart disease. When we think about heart rhythm abnormalities, what people tend to notice is palpitations. What's palpitation? Palpitations are quite frequent. There might be a skipped beat, a sudden jump in the heart. It might be a flutter in the chest that continues for some seconds or some minutes, and that might be an indicator of heart rhythm abnormalities. Another thing that's commonly seen in heart rhythm abnormalities are weak episodes, dizzy spells, or indeed blackouts. So there's certainly a lot that we see as cardiologists when patients come to us for the first time, but discomfort in the chest, breathlessness, palpitations, weak episodes, blackouts. Those are some of the common reasons that patients are referred to see us.
We know that our audience is very interested in whether women experience exactly the same symptoms as men. So could you talk about that?
Yeah, there has been quite a lot of research into that in recent years. And the short answer is that they experience quite similar symptoms to men. But they're more likely to experience symptoms which are not classic textbook symptoms, if you like. And we have tended to refer to these in the past as cardiologists as atypical symptoms. And that might mean that if we're talking about discomfort in the chest, that it's not the one that we classically associate with angina or narrowings in the heart arteries, that it might present more like a gastrointestinal type of pain, a pain in the upper abdomen, a pain that is perceived as an indigestion type of pain. Now, it's important to say that a significant proportion of men also experience this as their first symptom, but we think it's slightly more common in women rather than men.
Okay, David, moving on to the brain. Can I ask you the same question with regard to stroke? What are the typical signs and symptoms that people might experience and they should be watching for? And is there a difference between men and women?
So men and women tend to suffer the same symptoms and signs of stroke. There's generally no difference. The key features of a stroke are sudden loss of power of speech, loss of power of the face, arm or leg, or loss of sensation. And it usually tends to be down one side of the body. You lose power down one side of the body in the face, arm and leg. And the key thing is that often patients don't suffer pain. So it tends to be, it's painless. We talk about stroke is that you lose function. You lose function in speech in stroke. You lose power of speech. You lose power of your face, arm, or leg. Whereas with cardiovascular disease or with heart disease, the patients that Robert sees, they suffer crushing central chest pain, and that's one of the concerns that we have with stroke is that patients often ignore their symptoms because they don't cause pain. So that leads to a delay in presentation and looking for help. And that's one of the key messages that we would like to deliver today is that if there's any concerns around a stroke, it's important to seek urgent medical attention.
Okay, we've learned how to recognise a stroke or a heart attack or angina. If we want to avoid experiencing that, what are the risk factors that we should address? So David, maybe you'll tell us about the risk factors for stroke.
So thanks, Alice. Again, a lot of the risk factors that stroke shares with cardiovascular disease. So smoking history of high blood pressure, history of high cholesterol, a history of diabetes. All of these are the major risk factors that we talk about in terms of stroke. High body mass index, overweight, lack of exercise, poor diet. These are the general risk factors that we would see in patients who present to our service. And particularly with the increasing level of obesity, we're seeing younger patients presenting with these symptoms of stroke and cardiovascular disease, and that's a worry.
Robert, anything you'd like to highlight in particular for risk of heart attacks and angina, in addition to what David has offered?
Yeah, no, I think David alluded to it, that actually the risk factors are generally shared risk factors for vascular disease, for stroke and for heart disease. And we heard of the main risk factors there. I suppose there's some evidence to suggest perhaps blood pressure is associated more strongly with stroke than in certain types of heart disease. But broadly speaking, most of the risk factors are the same. Cholesterol is one that receives a lot of attention, and that's been the case really over the course, I suppose, of the last 40 years or so, where more and more research has focused on the blood cholesterol that's in your body as being an important risk factor for heart disease. And it's important to realise that all of these risk factors, they kind of interplay with each other. And we've kind of moved away from defining absolute normal levels of cholesterol, if you like, but certain levels of cholesterol might be satisfactory for some people in the population, but in other people because of a constellation of risk factors they have that might be significantly too high for them, and that might cause problems with narrowings of the heart arteries.
A quick word on family history and genetics. How important are they?
So again, if we talk about common things like coronary artery disease, we say that it's a multifactorial condition. So there's modifiable risk factors and non-modifiable risk factors, and the main non-modifiable risk factor is the genetic makeup that you're born with. And I suppose because heart disease is very common in the Western world, we can sometimes fall into the trap of thinking that everyone with heart disease in their family is at very significantly elevated risk of heart disease, but it's somewhat more subtle than that. And we tend to rely on, well, is there a family history, for example, of precocious coronary artery disease or coronary disease at a young age, which would mean in a male, first degree relative, onset of the condition at an age below 55, or in a female first degree relative, onset below 65 years of age.
Thank you for that. Now, David and Robert have described the risk factors, and I wonder if I could bring you into the conversation, and could you clarify which of those risk factors are modifiable that we as individuals, with the help of health professionals, can intervene on and make it less likely for us to have a heart attack or stroke?
Yeah, thank you, Alice. And that's a really important question. So I think really all of the risk factors for cardiovascular disease are potentially modifiable, and they're modifiable through lifestyle behaviour changes. So there are kind of key health behaviours that are within our control, that if we work on improving them, they actually improve our risk factor profile and maybe prevent us from having a cardiovascular heart attack or stroke, or they delay the onset of cardiovascular disease. And there are key behaviours that would be smoking, as an example. So smoking is something that people should not do. It's a very simple black and white message. You should not smoke. Alcohol intake is important, so modifying alcohol intake. Binge drinking is linked to things like stroke, for example, and binge drinking is drinking 6 or more drinks in one occasion. Sleep is very important, so people look after their sleep and their sleep hygiene. Physical activity is important, so increasing physical activity, looking after your nutrition, and things like social connectedness are also important. So, social support has been shown to be a major support to people in terms of just managing their health and their well-being. So all of those are modifiable behaviours that people can work with in terms of just improving their health and preventing cardiovascular disease.
So it's all very well to know that we can modify them.
Mm-hmm.
So how can we actually help people to achieve that beneficial behavioural change?
So I think it's very easy to say modify your health behaviours, but it's actually very difficult to do. So any intervention around health behaviours would be considered to be a complex intervention, because you're asking people to change their daily habits, and that's not an easy thing to do. So typically you can work with a health professional, or it's something you can do yourself, but we would talk about stages of change. And if you're working with a health professional, you're being guided through those stages. So the first thing is to acknowledge that there's a problem, or that there's something you would like to change. So maybe you feel your diet is not great and that it could be improved on. You'd like to increase your physical activity. You want to stop smoking, which can be very difficult. Maybe your sleep habits are not great. So all of these things can be changed. And the stages of change really are firstly to acknowledge what it is you want to do, and to decide then that you're actually going to do something about it. So the first stage is that acknowledgement. The second stage is to plan to do something about it. The next stage is to actually do it, and that's hard. So usually we'd be recommending to people that you simply set a date, you communicate with your loved ones that you're going to do this so they can support you, and then you start to implement the behaviour change. You maybe increase your physical activity, change your diet, whatever it is. And then really ideally by just continuing to do that, it becomes part of your routine, then it becomes part of your habit. We talk about tiny habits or atomic habits, do it in small stages, gradually build up to making what might be quite a profound change to your lifestyle. And once you get to that stage where it becomes a habit, then you're at the maintenance phase. And to an extent, you mightn't even have to think about it anymore because you've made the change. But it is possible to relapse. It's very hard to make behaviour changes. So if you relapse, really the thing is not to be too hard on yourself and just kind of get back in the saddle again and re-implement the change that you want to make. So I suppose just being kind to yourself, not being too hard on yourself if you relapse, and just get back again, into the groove of making that change. So that's essentially the way you would guide either yourself or work with a healthcare professional around making lifestyle behaviour changes.
Thank you for that. And we're going to move on to treatment. And in fact, Anne, I'm going to come back to you again because I know you were very involved in the FAST campaign.
Yeah.
So can you tell us about the FAST campaign and its importance for stroke management and treatment?
Sure. So the FAST campaign is a really effective campaign that was run here through the Irish Heart Foundation. And the idea of it really was to increase population awareness of stroke warning signs, so common stroke warning signs that David's already alluded to. So FAST is an acronym that stands for face, arm, speech and time. So very common symptoms of stroke would be a facial weakness, so one side of your face dropping maybe, so it's a very visible weakness. Weakness on one side of the body, so that's captured by arms. So if you have a sudden inability to use your arm, that would be a major sign of stroke. Speech then is the other major sign. So if you're finding it difficult to speak, or if you're wanting to say something but other words are coming out, that'll be an indication that there might be something going on. And then T is for time. And so the big message really of the FAST campaign is that time is brain. So for every minute that passes, there are more brain cells being damaged. And so it's really important that you ring an ambulance. So not contact your GP or phone a loved one, but actually contact an ambulance and get to hospital as quickly as you can. Because the idea is that you have a scan and there's an intervention then which will hugely improve your outcomes. So the idea would be that you get to hospital within 3 to 4.5 hours. So that intervention can actually happen, and then your outcomes are greatly improved. In terms of, we've done research around the FAST campaign, and what we have found is that the population picks up on the symptoms so that people understand what the symptoms are, but the T part of the FAST message tends to be lost, and it is really important that people understand that you have to contact an ambulance and get to hospital very quickly. So that you have the best possible chance then of recovery.
So minutes are important rather than hours.
Yes, absolutely.
David, can you elaborate on that? Why is it so important, or what are the benefits of people seeking immediate help if they think they're having a stroke?
Yeah, we use this term time is brain, and for every, as Anne says, for every minute we don't treat a stroke, we lose, or 2 million brain cells die. So it's very important that patients seek immediate attention because of the treatments that we have to offer are time dependent. So for example, there's two major treatments that we can offer for patients who've got what we call the most commonest kind of type of stroke, called an ischemic stroke, which is usually caused by a blockage of a major blood vessel in the brain. There's two ways that we can unblock this artery. One is by giving thrombolysis, which is clot busting treatments, which dissolves the clot. But more recently, since 2015, where the studies have shown us the benefits of this new treatment, is called thrombectomy. And basically what that does is that a radiologist goes into the brain and removes the clot from the artery that's causing the blockage in the brain. And that again is time dependent. The earlier that we can unblock this artery, either through thrombolysis or by thrombectomy, the better the outcome for the patient. And there's 2 centres in Ireland that can do this treatment now, one in Beaumont Hospital and one in Cork. And we're very fortunate because this service or this treatment is not readily available in other centres in the UK and Scotland where I worked in the past. So we're very fortunate to have this time-dependent treatment that we can offer patients who are suffering a stroke. And again, key thing is time is brain. Seek urgent medical attention to provide a better outcome for our patients.
Thanks, David, for describing the wonderful new treatments that we've developed over the past 5-10 years for stroke. Coming back to you, Robert, can you tell us about all of the treatment options that are available for heart attack in the coronary care units throughout the country?
Yeah, well, I mean, like David said, actually there's a lot of commonalities between arteries in the brain that are blocked and need to be opened rapidly, and arteries in the heart that are blocked and needed to be opened rapidly. And we talk about acute coronary syndrome, or we talk about a heart attack in evolution. And again, we're lucky to live now in a time where options to open the heart arteries are available around the clock, 24/7, 365 days a year in all the major population centres around Ireland. And over the last 8 to 9 years, there's been great work has been done to develop a coordinated network of centres. So wherever you are in Ireland, if you have a heart attack, you'll be triaged to one of these heart attack centres. You'll be brought there, and if appropriate, the heart artery will be opened regardless of the day of the time of day or the night time. So I suppose the first thing when someone is suspected of having a heart attack is an ECG is done, and this basically allows the doctor or the ambulance personnel to make a decision. Is this somebody who with a high probability has a blocked artery and needs to be triaged immediately to a heart centre to have the artery opened, or is this a more grumbling type of a heart attack where they'll be brought to the emergency department, admitted to the hospital and treated along a different pathway? So this primary angioplasty, as we call it, is a straightforward procedure. It's performed through a very small nick in your wrist artery. A catheter is brought up to the heart arteries, the coronary arteries. The blockage is identified, and the blockage is opened with a balloon, and then the result is secured by implantation of a stent. So this has been a major development in recent decades. You alluded at the outset to coronary care units, and coronary care units came in maybe 20 years before the availability of this technology, and already played a huge role in reducing mortality due to heart attacks, purely by having patients closely observed for the initial hours when they're in the throes of a heart attack, where very serious heart rhythm abnormalities can occur, and the medical staff need to be aware of those and react promptly to provide life-saving care. So I suppose those two areas in the treatment of heart attack have been the most notable successes in recent decades. And the third area then is the development of medications, which have essentially been potent blood thinning medications to help stabilize the blood of patients who are having a heart attack, where clots are very likely to form. And I think those three areas have been key developments.
Thank you very much. Now, Anne, I'm going to return to you. David and Robert have described all of the wonderful treatments when people are having heart attacks and are having strokes in order to minimise the damage. But unfortunately, some people survive their stroke or their heart attack, but they suffer some damage. And you're a particular expert on the brain consequences of strokes and the rehabilitation that is available after suffering a stroke. How do we help those patients who have had a stroke that has left them somewhat disabled?
Mm-hmm. Yeah, thank you, Alice. So, I mean, there have been huge advances in stroke treatments in the last 5 to 10 years, but for many people they may still have some level of what we would call residual deficit, or there's still some problems after the stroke. For many people, they experience a weakness on one side of their body, the side opposite to where they had the stroke, and so they need physiotherapy to be able to regain function in their, typically arm and leg could be affected. So those kinds of physical function difficulties are common after stroke. Equally, there are speech difficulties after stroke, so you may have difficulty understanding what people are saying to you or communicating. So maybe just a physical difficulty in articulating the words that you want to say, or a difficulty just expressing yourself. And so speech and language therapy would be very common as part of post-stroke rehabilitation as well. People also may need some help with activities of daily living, and particularly for younger people with a stroke, they may have difficulties getting back to work. And so typically occupational therapy will work with patients after stroke to help them, to rehabilitate them, to regain their normal daily function, including returning to work. So they would be very common forms of rehabilitation after stroke: physiotherapy, occupational therapy, speech and language therapy. But there are other areas that tend not to get rehabilitation. So a lot of people will experience very profound fatigue after both heart attack and stroke. And it can be very debilitating and prevent them from going back to work. And it's demoralising. So often they will talk to their healthcare practitioners about that, and there's not a lot that is being done in terms of rehabilitating that currently. Other common after effects of heart attack and stroke would be mood issues. So people can often experience depression after having a cardiovascular event, or they're extremely anxious that they're going to have another heart attack or another stroke. And so they're fearful about maybe going back to exercising. They have worries about their diet, all of those kinds of things. So it's important that there is some engagement with people around their anxieties and maybe feelings of depression after stroke. And it might be that they need to take medication for a short period to help them through that. And then the final one, which is an area that I would do a lot of research in, would be cognitive difficulties after stroke. So cognition means your thinking, and after stroke people can often find that they have difficulties with concentration, with maybe planning, with navigating their way, around maybe their own neighbourhood even. So just, things that they would have done very easily before their stroke, they now find they have difficulty with. They may have difficulty with their memory, concentration, attention, and problem solving and planning. They would be the typical areas. They tend not to get rehabilitation after stroke at the moment, and that's not just an issue in Ireland. That happens in many other countries as well, and it's an area of rehabilitation that needs to be focused on and developed. So that's an area that we're currently working on here in RCSI.
Well, thank you for doing that work and for improving the outcomes for people post-stroke and post-heart attacks. So finally, we're going to wrap up, and I'd like to ask each of you to tell me and tell the audience what your key take-home message is for the viewers that they should remember and guard against into the future. So Robert, I'll start with you.
Well, I'd start probably with a straightforward message, a simple message, which is that prevention is better than cure. It's an old medical adage, but we've learned a lot over recent decades, as we outlined in today's discussions, about what the risk factors are for heart disease, for cardiovascular disease. So I think it's important that people are proactive. Certainly if you've gotten to the age of 35 or 40 and don't know what your cholesterol is, you should know what your cholesterol is, you should know what your blood pressure is. And it's very important that we take ownership of these risk factors that change with time as we get older, and certainly need to be reassessed. But I think making the important lifestyle changes that we alluded to in terms of physical activity, in terms of diet, in terms of alcohol, in terms of smoking, are critically important in preventing heart disease. And that's probably the main message from me.
Okay, prevention is better than cure. David.
As I'd agree with Robert, prevention is better than cure, and I'd add particularly in terms of stroke, there is a certain condition that we should highlight tonight as well, is atrial fibrillation, which is an irregularity in the heart rate. And as we get older, we get this irregularity in the heart rate that can cause and lead to heart failure, but also to stroke. So there is a campaign out there about feeling your pulse. If you feel that your pulse is irregular, you should go to your GP and have it confirmed with an ECG, a very simple test that can be done, because that has a significant benefit to us as patients, because then we can avoid clots in the heart which can lead to a stroke. So very important message in terms of prevention. But I suppose my main take-home message in terms of stroke is that if you think that you're suffering a stroke, you should seek urgent medical attention. Don't wait for the symptoms to resolve. And if they resolve within a couple of minutes, it's still a threatened stroke. And that's what I say. We often talk about, use this term, a mini stroke, and people often discount it. It's only a mini stroke. But actually a mini stroke is just as important as a major stroke, because a mini stroke can lead to a major stroke. It's important to seek urgent medical attention. Time is brain. The treatments that we can offer patients are time dependent in our hospitals, so always seek urgent medical attention if you're concerned that you've had a stroke.
So don't ignore stroke symptoms.
Indeed, yeah.
Anne?
Yeah, I suppose I might add to that in terms of a take-home message, which are just to know the symptoms of stroke. So the symptoms of stroke would be a facial weakness, a weakness on one side of the body, so the arm dropping, or a weakness in your leg, issues with your speech, face, arm, speech, would be very common symptoms of stroke. And as David said, to just act immediately and contact the emergency services and get to hospital as quickly as you can.
That concludes our discussion for today. My thanks to our guest speakers, Professor Robert Byrne, Professor Anne Hickey, and Professor David Williams. Further details about upcoming events in the RCSI MyHealth Series can be found on the RCSI website. From all of us here at RCSI University of Medicine and Health Sciences, thank you for watching and stay safe.